Hey everyone, welcome back. Today we're talking about the ST segment of the ECG and its relation to ischemic heart disease. Now, if you've ever used an ECG to diagnose ischemic heart disease, the ST segment is the segment you're going to want to look at the most. So let's get right into it. Right? Why is it important? Well, you know the classifications of ischemic heart disease, right? It's unstable angina, STEMI, and STEMI. And what do those mean? STEMI, non-ST elevation myocardial infarction. STEMI, ST elevation myocardial infarction. So the only form of ischemic heart disease you can actually diagnose on ECG is the STEMI, because that's the only thing you're going to see signs of. With all three of them, your patient is going to come in with chest pain and symptoms of myocardial infarction or ischemic heart disease, and at that point you're going to have to differentiate between unstable angina, STEMI or STEMI. And the differences are important because with a STEMI, you're going to want to do immediate intervention. Either percutaneous intervention, so you're going to want to take out the clot, that's within 90 minutes of presentation, or you're going to want to do thrombolysis. But you're not going to do that for unstable angina or an STEMI. How do you differentiate then between unstable angina and an STEMI? Well, what you do then is you look at the troponins. In unstable angina, troponins will not rise because there's been no ischemic damage to the heart muscle. In an STEMI, you will get a troponin rise. And in a STEMI, you'll get troponin rise plus ECG changes. And that's what we're looking for here. What are the ECG changes in a STEMI? So, to measure ST elevation, right, to diagnose ST elevation, you've got to have at least 1 millimeter of ST elevation in the limb leads, in at least 2 consecutive limb leads, or, if your patient is male, 2 millimeters ST elevation in the chest leads. Female patients, 1.5 millimeter ST elevation in the chest leads. And that is what you're looking for. So we're going to go into more of the intricacies of it now, but essentially, that is what you're looking for. And make sure to subscribe to the channel for more content like this and for more med student practical tips and content knowledge. So what are the changes in a STEMI? Right? To be able to diagnose it, you need to know what you're looking for. And a STEMI is an evolving process. It's a dynamic process. A STEMI doesn't look the same if you see it 10 minutes after versus 2 hours after. The ECG changes. So what do you look for? At the beginning, you'll see the T wave starts to become closer and closer to the QRS complex as time goes on, till eventually the T wave sits right on the QRS complex, giving you ST elevation. Normally your ST segment is isoelectric, so it sits at baseline. But as the T wave moves closer and closer to the QRS complex, you get a loss of that isoelectric ST segment and you get full-on ST elevation. From there, your Q waves start to develop. Remember we talked about pathological Q waves? Now you start to get Q waves in the STEMI. After your Q waves develop, your T waves become biphasic. So now you've got ST elevation with biphasic T waves. And after that, now this will be hours after that, which is a sign of a missed STEMI, you'll get inverted T waves with deep Q waves. If you see inverted T waves with deep Q waves, you have missed the STEMI. It happened a few hours ago, and you didn't catch it. And a month after a STEMI, all these changes are gone. Your ECG looks normal again, except for your pathological Q waves, which stay. Remember, a pathological Q wave is a Q wave that is 25% or more of the total amplitude of the QRS complex. So a month or two after, you won't see any signs that there was a STEMI except for that pathological Q wave. And that pathological Q wave is your clue that there was something wrong. Now another thing that you can look for, another presentation of this. Patient comes in with chest pain and a new left bundle branch block. That is also indicative of a STEMI. Now remember, you can only say it's a new left bundle branch block if you have an old ECG. So if your patient comes in with chest pain and a left bundle branch block, you don't have an old X-ray, you can't assume that it's new. But if you have an old ECG, and you can see that this left bundle branch block is new, your patient's having chest pain, you treat that as a STEMI. Now that's how you recognize a STEMI, right? That's what you look for on an ECG. But how do you tell where in the heart this is affecting? How do you localize that STEMI? That's what we're going to talk about next. So, if your ST elevation occurs in V1 and V2 primarily, that is a septal MI. And that area, the septal area, V1 and V2, is supplied by the proximal left anterior descending artery. If it's V3 and V4, we call that an anterior MI, and that's also supplied by the left anterior descending artery. Now if it's in V5 or V6, we call that an apical or a lateral STEMI, and there are several arteries that supply V5 and V6, or in the lateral area of the heart. And these arteries are either the distal left anterior descending artery, the left circumflex artery, or the right coronary artery. If your ST elevation is in 1 or AVL, that is a high lateral STEMI, and that is supplied by the left circumflex artery. If your ST elevation is in 2, 3, or AVF, that's an inferior STEMI. 2, 3 AVF is inferior. 90% of the area in 2, 3, and AVF is supplied by the right coronary artery, but 10% is supplied by the left circumflex artery. And the last few leads is V7, V8, and V9. If you've got ST elevation in V7, 8, and 9, we call that a posterolateral STEMI. That's also supplied by the right coronary artery and the left circumflex artery. And that actually brings us into the next part of this video very nicely, because what are V7, 8, and 9? We only go up till V6. But the ECG typically does not cover the right ventricle and the posterior left ventricle. So what we do is we use reciprocal changes to measure actual ST elevation. What I mean is we use V1, 2, and 3, and we measure ST depression in there to check out ST elevation in the areas behind it. For the posterior left ventricle or for the right ventricle, you look at leads 1, 2, and 3, and you check if there's ST depression. If there's ST depression in V1, 2, and 3, what that means is reciprocal leads V7, 8, and 9 should show ST elevation, which is a sign of a posterolateral infarct. And now if you've got ST elevation through all the chest leads, right, V1 to V6, we call that a wide anterior STEMI. And what that means is you've got an occlusion in the proximal part of the left anterior descending artery. So almost the entire left anterior descending artery is blocked off, so you're cutting off supply to a large part of the heart. So if you're still struggling to remember where the arteries go and the localization, I've put a link down below which will show you which parts of the heart are supplied by which arteries and how you can localize it, just to make it easier to remember. You've got to remember that a wide anterior STEMI can also present with cardiogenic shock, because so much of the heart has become ischemic, it may not be able to deliver oxygen efficiently throughout the body. I hope you liked the video. This is the last entry in our ECG series for now, so if you want to review, you can go back and check out any of those videos on any of the parts that you still want to review or you didn't understand fully. And if you have any questions, comments, or anything you'd like me to clarify about ECGs or the ST segment, just let me know down in the comments. Leave a like if you liked the video. Thanks everyone, see you next time.